when you think of infection? Somebody shout something out. Increased white blood cells. Fever. Inflammation. Anything else? Sepsis. Drainage. Pus. Antibiotics. Good. What else? Gentamicin. So gentamicin is one of your medications that are listed on your objectives. There's not this whole laundry list of antibiotics, though. And we're going over 4 different exemplars for infections. So cellulitis, pneumonia, UTIs, and then like the big oh no moment, sepsis, right? But I don't want you, besides this medicine that we'll talk about in a couple of minutes, I don't want you guys to get so wrapped up in all of these different medicines that your book is going to mention. They're going to talk about macrolides and cephalosporins and fluoroquinolones and all different Bactrums and nitrofurantins. Don't get so absorbed in that, okay? Don't like waste all of your time and be like, I have to know this specific drug. Know what's on your list. What I want you guys to have an understanding of is we're going to talk about certain cultures, like sputum cultures and urine cultures. So when your patient goes to a provider and they have signs and symptoms of, let's say, a urinary tract infection, they do a urinalysis, which we'll talk about, and the provider says, yeah, you got a urinary tract infection. What that provider does is put them on a broad spectrum antibiotic that covers a lot of different things. And then they get a culture prior to antibiotics being started, and once the culture gets back, the culture will tell them, hey, this is the one. This is the antibiotic that's going to do it. This is the antibiotic that's really going to hit this bacteria really super hard. So I want you guys to have an understanding of that your patient may come into the hospital, and on day 1, day 2, or maybe even prior to the hospital, they were started on one antibiotic. And then as the cultures and sensitivities come back, that antibiotic might change, okay? Also, sometimes cultures aren't done, right? Who's gone to their primary care provider and they get diagnosed with bronchitis, and the primary care provider is like, here's a Z-Pack for you, here's some amoxicillin for you. Who's that happen to?
Oh, yeah.
Right? What happens there? Nobody's doing a sputum culture, right? Who has actually coughed up sputum and put it into a cup for their provider and be like, Merry Christmas, here you go. So, no. That doesn't happen very often. That's because we also know that certain bacteria live in certain places, okay? 90% of urinary tract infections are caused by E. coli. So when your provider puts this broad spectrum antibiotic at you, they are looking for things that are going to cover E. coli because they know that that's where that lives. They know that that's where that's going to be breeding. Your skin, staph infections are pretty common, so they know that they're going to be looking for things like cephalosporins that target staph and stuff like that. Okay? So that's really all I want you to know about the broad antibiotics, right? Otherwise, gentamicin. Gentamicin is what we call an aminoglycoside. It is indicated for normally very serious gram-negative infections, okay? So, relating that to what we are looking at, we think of VAP, which is ventilator-associated pneumonia, right? Healthcare-associated infections such as pneumonia or even wounds. Again, it covers like gram-negative, and then it can cover some infections caused by staph when penicillins or less toxic drugs aren't going to work, okay? Big things, it has a black box warning. What's a black box warning?
Pregnancy.
Right? It can be, but not pregnancy categories are different. But a black box warning is a what?
Is it like known damage?
Yeah, like it's like this could happen, and it's not good, okay? So ototoxicity, very good. Does anybody else know another black box warning for gentamicin?
Nephrotoxicity.
Nephrotoxicity, right? Those kidneys. Okay. There's one other one. 2 other ones. Sorry. So neurotoxicity, and then there's a neuromuscular blockade. So again, like pretty heavy hitter, right? Like you've got to really need to use this medication. Something that you're going to monitor when using gentamicin is something something called a peak and a trough. Can somebody tell me about that? A peak and a trough?
When medicine is at its peak in your body system when it's working, and then the trough is the level after it's been processed, like the low.
Right. Okay, that's good. Good. So we look at peaks and troughs because we want that antibiotic to be at a certain serum concentration, right? So that it's at a serum concentration when those bugs and germs aren't multiplying. So what they'll do is they'll take a peak about 30 minutes before the actual dose is given, and then the trough level is just before the next dose. So if you were hanging a 6 a.m., you'd be taking a trough level right before that next dose is due. So before it gets infusing, before you hang it up, and then the peak is 30 minutes after a level, or I'm sorry, after a drug has been hung or given, okay?
Wait, go back.
Yep, a peak is 30 minutes,
Before
30 minutes after a drug has been given is your peak. Right before a drug has been given is your trough. Okay, think trough low. So when those medications, they have half-lives, right? And so they start here, they normally go up, and then they slowly kind of come down. So think of a trough as something low, so it would make sense that you take it before your next dose because your serum concentration levels should be lower then. Does everybody have that? We're all good on the peak and the trough? Yeah?
I'm not really understanding like what exactly like the peak and trough exactly is. Like I know like when to give or like when to get them, but like
Okay.
peak is like when.
So it's what we're looking at is again those like concentration levels of the medication in your blood. And with antibiotics and a lot of other drugs, we want those at a certain level because we know then if it's at these certain levels that those bacteria aren't going to multiply within that serum concentration level. Yeah.
So do you take a peak and a trough with every dose?
No, some of them it'll depend. It will depend. For vancomycin, it's different than gentamicin. It will be dictated to you when the peak and the trough should be taken. Okay? And a lot of times pharmacy will dose on either the peak or the trough.
So we're doing like a blood test for this?
Yep.
And
Yeah.
wait for results to come back before administering the next dose, or will it be like?
Again, it's all going to be within your order. So I know that can be a little confusing, but for like vancomycin, they may say, okay, take a trough, and then if it's not within a certain level, they may adjust the dose on it. So just look at your order. The important thing that I want you guys to know is when to take a peak and when to take a trough. Okay, so that if the order says a peak level, you're not taking it at the trough time. Okay? All right. Did I lose my clipper already? So early.
Right there.
Thank you.
Nope, come back.
Got it.
Yeah.
Okay, so we're going to talk about cellulitis today. All right? And your professors decided it would be a really great idea to put together this video. So, let's kick it. You guys hear it?
Oh no, you need to turn this up.
I'm trying.
It's hot, TC is low, and temperature is slow. If you're breathing fast and the neutrophils are rising, sepsis is here, and you're on the horizon.
I shouldn't give up my day job, huh?
Are you posting that?
Yeah, I'll probably post that. So that, what did you say?
I'd like to hear the words.
Oh,
It's hard.
so we do have the lyrics. Okay, we do have the lyrics. But that was just a really brief overview of cellulitis, right? So what we're going to do as a class is we're going to do a concept map. About, not individually, we'll do it as a class, okay? But from that video, what did you guys hear? What were some of the words, like the key phrases and the words that you guys heard?
Especially my hearing. Alright, elevate that.
Cellulitis what? Inflammation, great, from the warmth and the redness, okay? What else?
Yeah.
Slow cap refill, right? So these are like the end there with signs and symptoms of sepsis, right? We're going to talk about that on May 6th, but that's something that should always kind of be in the back of your mind when you have patients that come in with infection. Sepsis can set in, and it can set in quickly. And it can be deadly, it can lead to septic shock. And that's something that is really serious. So you guys really kind of want to have that on your horizon, like looking for those signs and symptoms. Again, we'll talk about that next week, but just realize any of these can lead down that road, okay? What else? Elevating, right? Why would we elevate? Why would you elevate, let's say, an extremity that had cellulitis in it? Swelling? Good. To help promote blood flow, right? Because what happens with inflammation? What comes driving in? White blood cells. It brings in fluid, right? Okay, so sometimes that fluid gets so much that the skin will weep and it'll actually start coming out of the skin. So what do you think is happening inside? Right, things are getting squished, right? They're getting squished in there from all of that edema. And so helping that leg out by elevating it can help some of that edema come down. What else do we see in the video? You can get it from a bug bite. Pretty common in children, okay? As far as lifespan stuff, kids a lot of times will get bug bites, and what do? Scratch it, right? I always say it's not the itch, it's the scratch. And what's underneath it here? Dirt and germs and yuck, right? So it's not the itching that causes problems, but it's the actual scratch that causes the problems because that opens up the skin and opens it to bugs, right? Bacteria, all kinds of stuff to actually get in. Because the skin's our #1 defense, right? It's one of the largest body system that we have. And it helps protect us against all of these things that naturally live on our skin. But once you open it up, it allows it to get in. The worksheet that you guys had for your pre-class stuff, it went over, what is that called when things get in? What? Chain of infection, good, that's what it was, but what is it called? Good, portal of entry, okay? So it has to be able to get in for it to have an effect on us systemically, all right? So what were some of the other interventions? Lotion, right? Why lotion? Keeping it moisturized, right? So if it's moisturized, it's not going to itch, okay? Bugs like dry areas, all right? Somebody said washing their hands, right? We all know it's the best way. Keep your nails trimmed so that they're not sharp, without sharp edges. Making sure that they're not only cut, but they're filed so that they're nice and soft and they don't have any snags to open up that skin. What are some other things? All right, let's do this. Let's put a concept map up on here. All right, we're going to put infection in the middle, or cellulitis, sorry. All right, so we kind of already talked about clinical manifestations, right? So As far as clinical manifestations go, do you think it's a chronic onset or a rapid onset? Most of the times it's rapid. You experience some kind of rapid onset and the patient's going to appear ill, all right? We talked about redness, otherwise known as erythema. Good. Where does it happen? Okay, but where on the body does it happen? Right, it can happen really anywhere. All right, we see it a lot on the face. When it's on the face, sometimes kids can have what's called impetigo, and it can get just like crustiness to it. Nothing that you guys have to know. Okay, so don't go hurrying writing that stuff down. Just know that certain infections can lead to cellulitis also. They'll get it sometimes on a limb. It can happen when there's abscess present, or even from things like sinusitis. People can get orbital and periorbital cellulitis, and that's where the eye really whoosh. And that can be actually from a cellulitis. How do you think these people feel? Horrible, right? Now what does that mean?
Hot, itchy.
Okay. Are they got a lot of energy?
No.
No, they're pretty lethargic, so they're fatigued or lethargic. We said redness, right? What do you think that area is going to feel like when you touch it?
Warm.
Hot. Yeah, warm. And somebody earlier said fever. Okay. Anything else? Oh, geez. Anything else you guys can think of? Might be irritable. Yeah, they might be. They're not going to feel good, right? They're probably not going to feel good. Do you think?
They risk for like dehydration with all that inflammation.
So possibly more with the fever. Okay. So people that have fevers can be at risk for dehydration. They're obviously warmer. They're tachycardic. They're tachypnic. Those types of things. What do you think about if I had a cellulitis here? Let's say I got, this actually happened to me. So perfect example, I got a bug bite right here on my arm. Okay, it was around the 4th of July because I had to call the on-call doctor. And I look at it and I'm like, that's a little red, a little irritated, it's a little warm, right? So I circle it. The next day, it's outside of the circle. Okay? I'm like, that's not right. See what happens. Call the doctor. Fine, here's some Keflex, because Keflex is commonly used for cellulitis or skin infections. And the next day, I'd only had one dose of Keflex in me, and the next day I've got a Lyme. What do you think that is? Right, where is it spreading to? What do I have up in here? Lymph nodes. Yep, okay. So it spreads and you can get lymphangitis also on top of your cellulitis. Okay, so look for lymph node enlargement. Okay, I'm going to hit that thing a couple of times. All right, so you've got this person with all these things. What is a priority assessment? What are you guys going to look at? Skin. Good. What else? What are you going to do for this skin? Sorry, let's start there. What are you going to do for this skin? What are you looking at? We already said a couple of things, but what are you going to do? Okay. Good. Keep it clean. Wound care. All right. What else?
Cover it.
I'm sorry?
Cover it.
Okay. What else? Measure it. Very good. What did I say I did? I put a circle around it, right? So you're actually going to mark the edges. And I'll show you a picture of that in a second, okay? So you want to mark the edges. You want wound care. You want to cover it. What other things as far as your skin?
And some like topicals for skin integrity.
Okay, so they may have some type of topical antibiotic, but if you are if you have cellulitis, you're probably past the topical, and you're probably on a what? Systemic antibiotic, yep. So you're going to administer an antibiotic. That's just my abbreviation for antibiotic, ABX, okay? What else are you going to do? With your wound care, do you think you want it to be dry, or do you think you want it to be wet?
Probably going to be wet, right? Because of vitamin A.
It might be wet. So there's a lot of newer research out now about healing wounds wet or healing them dry. Moist wound beds heal better. Dry wound beds, that actually slows the healing. So we like to see a moist wound bed. It helps prevent the cell death. It improves the rate of epithelialization, which is just that turnover of epithelial cells. And it protects the wound from infection. Again, what do bugs like? Dry, hot areas, right? That's why in this wintertime people get sick. Their houses are dry and hot. Okay. What else can we do? Do you think it's going to hurt? Yeah.
I had my clinical guy was there and they had these like foam boots on.
Okay.
I don't know, I guess to keep like on pressure.
So, were they pink?
No, they weren't like the foam, not like the heel protectors.
Not the heel protectors?
They were like a full like leg, like from his knee down to his foot. It was like, it wasn't foam, it was like, I don't know, it's just like cushioning.
Okay, so I would, without seeing them, I would assume that could be for like pressure reasons, but I don't know what one he had. So that might have just been specific to whatever was going on. Was it both of his legs?
Yeah.
Yeah?
His legs would say, yeah, he fell out somewhere.
Okay, all right,
I don't know why it was that way.
okay.
I guess
It could
he's
be.
also in a lot of pain too.
Maybe it's helping to relieve the pressure, right? There's non-farm management of pain. Yeah?
Bacteria like wet environments.
What do you mean?
Like moist environments, I'm just saying like food and moist.
So you're saying that bacteria like wet environments?
Yeah, don't they like wet environments? Like, yeah, warm and moist environments.
So when you say warm and moist, I think fungus, like yeast infections, candida infections.
That's why they tell you like make sure your ears are dry when you get out of the shower and stuff like that.
Okay. So do you think certain bacteria live in that environment maybe?
I'm saying you got humans probably not like to live in there, like you know, like obviously clean it up and everything, but
So I want you guys to look, who has their book? Who has their book with them? Okay, I have mine. So I want you guys to take a gander, because it's a great question, right? Let's see. There is on page 598, and it's an evidence-based practice little blurb that actually is in the book about moist wounds and why it's better. So I want you to go ahead, just take a look at that. If you still have questions, and come on back to me. Okay, we'll take a look at it when after class even, yeah.
Like, I get what you're saying, but also, like, my grandmother recently had cellulitis due to a yeast infection that was, like, under her breast where it was moist and damp. So
Right.
in that situation, like, they would want to keep it dry.
Right, so if it's wet, dry it. If it's dry, wet it. That's kind of the idea, right? So people that have, like you were saying, like a fungal or like candida infection that could be underneath the breast, or people that have a pannus, like underneath the pannus of their skin, they like, fungals like that moist area. So it also may be dependent upon what's causing the infection. But in that case, there might be a powder that they apply, like a nystatin, something like that powder, that will be applied underneath it there to actually help dry it out a little bit and give it the antifungal. Other areas, if it's really dry, they might use a nystatin cream. So that could be, it could be dependent upon what's causing it. There's just, like I said, there is some research that shows that moist wound healing is better. But again, specific wound, right? Specific bug, okay?
I just remember when my daughter had her castle burn, she got it wet, so I called the doctor and he remedied all this and
Mhm.
she could get like a bacterial infection.
Mm-hmm.
So that, I guess, kind of like doesn't make sense with the whole
And I'm not saying that they're not going to grow bacteria. The research just shows that for wound healing, the wet, moist environment is going to be better. So bacteria, a lot of them like dry, hot environments. Again, some of them are going to breed. You're not going to see certain bacteria in lowlands, right? Like where it is wet and moist, and then you're going to see some bacteria where it's dry and hot. So you can't think of it as like one specific because there's so many different. Think of all of just the different gram-positive bacteria against the gram-negative bacteria. There's a ton of differences just within those two different categories. Okay? So maybe not think of it so much as like what's going to cause it, it's what's going to make the wound heal faster. Okay, yeah.
So like I know with my like acute care, they put like those like a moist yellow things on top of wounds, and then you wrap it. Is that like with that's with antibiotics in it? Is that part of like you're saying that the research is because they're open wounds? Is that different?
So there's a ton of different dressings that are out there. You can have dressings that are silver impregnated. You can have dressings that are antibiotic impregnated. You can have dressings that are just there to actually absorb the moisture because somebody said like, well, what if it's really weepy? Then they'll have a dressing that is changed like every 3 days, and that dressing is actually meant to absorb the excess moisture out of it. Okay, so it's going to be dependent upon whatever that dressing was. Okay? All right, any other questions on that? 596, though, it has a great little blurb on the moist wound healing. Okay?
That's all you did.
Yeah.
All right. So, what else are we going to do? We talked about elevating it, right? What about nutrition?
What about
Right. Okay, so you want to make sure these people are getting proper nutrition. We want to look at their fluids, right? Because what can they have from this wound? It's weepy, it's yucky, things are losing what we call insensible loss, right? Because they're losing liquid through that wound.
So it's like burns, essentially.
It can be like burns, but it doesn't, cellulitis doesn't have to weep. It can weep, but it doesn't have to weep. You may see it where it's really wet and weepy and blue, and you may see it where it's just real shiny and red, and it looks like really taut, the skin looks taut and tight, but it doesn't have to weep. It just might.
would you give antiseptic information?
You might give an analgesic, yeah, I mean, you might give something for pain. Okay, anything else that you guys can think of? What's another assessment you guys would look at?
Fever.
Fever, very good. Let me make this a little bit smaller. How is your patient going to look if they have a fever?
They're already red.
Well, the area's red, right? But how's your patient going to look? Flushed? Good. Tachypnic. They may be diaphoretic. They may be sweating. What else? So we have increased respiratory rate. We have increased temperature, right? Could potentially have an increased heart rate. It could be sweating.
You're worried about
Or they might have chills. Who said that? Good. Yep, they might have chills. Okay, what else? Are they going to be like ready to go? They're going to be like, yeah, let's go. Woo, going to the mall today. Like, yeah, they're going to be tired. They're going to be lethargic. What are we going to do for them? Good, antipyretics. What's really going to help them? What's going to bring that fever down? The best way to bring that fever down, besides like a Tylenol, don't think that route.
Break the fever.
Treat the infection, right? Treat the underlying cause. What else you be worried about if somebody had a fever? We said it already with the skin.
Watch out for sepsis.
Yes, watch out for sepsis.
Dehydration.
Dehydration, yes, because they are breathing, right? They're trying to blow off that hot air. They're sweating. So you want to look at the hydration status, okay? So you're going to do antipyretic. Oops, if I could spell it. Watch their hydration status. Okay, and then treat the cause. When would you call the healthcare provider? What is your something ain't right moment?
The temperature spikes.
Changing that
Temp
status.
spikes, you said that. Very good, temperature spikes. So if you have a temp that's greater than 38.3 degrees Celsius or greater than 101 degrees Fahrenheit, that's a phone call to the provider.
You said 38.3.
38.3 degrees Celsius or 101.
Really? That's considered a temp spike? 101?
When, let's say that Katie's in the hospital, she's been on antibiotics for 24 hours, okay, and she's not looking any better. Would you call? Yes, I would call. It's been 24 hours after the start of treatment, 24 to 48 hours after the start of treatment, and she's had no improvement. I pick up the phone.
Why wouldn't you just like wait for rounds the next day?
Let's say she got in and she was admitted to the floor at 8 p.m. and it's now 10 p.m. What are you gonna do? Rounds are at 8 o'clock the next morning.
I said she was like about the same though.
Right, but she's been on antibiotics for 24 hours.
Oh, I thought you meant 2 hours. Sorry, you said.
No. She's been on antibiotics for 24 hours. 24 hours since the start of treatment.
Okay.
Right? And so now we're saying she hasn't improved. Nothing's getting better. That's a call the provider moment. That's a something ain't right moment. Okay. We're going to talk about sepsis because all of these could potentially go to sepsis. We're going to talk about that next class, okay? So don't worry about all the signs and symptoms of sepsis quite yet, but know for now that all of these can lead down that yellow brick road, okay? What about labs?
Increased blood flow.
Culture, yeah.
Say it loud, say it proud. Good. White blood cells, what are we going to see? An increase in those. What else would you be worried about? Okay. What else could you potentially be doing? How about that? Let's start there. So a CBC, culture the wound. Why would we culture the wound? What do we want to know?
Make sure that whatever we're giving is going to treat it.
Good. And when we go over UTIs, we'll actually look at a culture and sensitivity, and you guys are going to tell me what antibiotics to give, okay? What else could you potentially be doing?
Do they screen for MRSA for like all skin infections?
Most of the time patients are, well, when they culture it, it'll just tell us what it is. It'll say this is the bug, right? But a lot of times they're doing MRSA screens when they come into the hospital. I mean, not necessarily in the wound. A lot of times I think they do it in people's noses, okay? What's another culture that we might see? This patient's sick. Like they are sick. Very good. Blood cultures. Yep. Can you think of any other culture or any other blood tests? Anything else? I'm sorry. Yeah. That will be included in your CBC if they did a manual or an automated diff. Yeah.
If you're giving aminoglycosides, do you want to keep an eye on your creatinine and BUN?
I would make the assumption, yeah, that would be antibiotic specific or medication specific, not specific. Specific, okay? Maybe a lactic acid.
Would that, like a BMP or CMP?
So the CMP is, the BMP is going to look at mainly your electrolytes, your BUN, your creatinine, all of that. The CMP adds on liver stuff, right? And then they may, like I said, they may draw a lactic acid. They're definitely going to draw that if they're thinking sepsis, right? But they may draw it just to kind of get a baseline to see where this person is too, okay? So just like I said, things to anticipate. What would be your priority? I still didn't hear you, I'm sorry. What would be your priority for a patient on cellulitis? Sorry. Or with cellulitis on cellulitis.
Culture the wound, give the antibiotic.
Okay, so that's actually super important, right? Katie said culture the wound, then give an antibiotic. When you do have a culture, right, you do want to make sure that you get it before administering antibiotics. Okay? Yeah, Chrissy?
No, I was just gonna say, if you're suspecting cellulitis, wouldn't you start them on an antibiotic? And then when I was in derm, that's what we did.
They may do, like I said.
And then
So,
culture it,
right,
and then
so
when it
they
comes
may
back,
do
we'll change it.
an empiric antibiotic, or like I said, those broad spectrums, but still, they would culture that
Yeah.
before they even started them on this broad spectrum antibiotic, such as like Keflex. Keflex is a pretty common one that you give for skin infections in general. So they would probably culture it, start them on the like I said, broad guys, and then once they get it back, narrow it down and say, okay, this is the one. Or they might say, okay, we're good with Keflex. Like, it's sensitive to Keflex.
Wouldn't one of the priorities definitely be like preventing further infection?
Yeah. Very good. Infection control, right? Very good. So Sarah said a priority might be preventing further infection. That's very good. We don't want this thing to spread. We don't want it to get any worse. So all of your standard precautions, making sure that you're washing your hands, you're having good hand hygiene, the wound is clean, you're following your wound care orders, all the things that we talked about for skin, elevating that limb, keeping it moist. They may do like moist compresses 4 times a day. They may have a sterile saline dressing to be slapped on their wound care now. They have got like a whole garage, I feel like, of different wound care dressings that they can do. I mean, it really is, it's amazing the stuff that they have out there. What if there was MRSA in the wound? What other precaution would you be on? Contact, right? So you'd be on contact isolation, okay? Do you think we want these people like up, moving, doing the jive?
No.
No, they're really gonna rest. Like, they're gonna rest, okay? All right. Any questions on cellulitis? So we talked about, the infection not spreading. We talked about getting the cultures and antibiotics. What would be your number 1 priority? Maybe at the beginning.
Give that antibiotic.
Getting culture and starting antibiotic.
Okay, so I want you guys to look at this picture. Because remember how we always say, well, it depends, right? And you guys are like, oh man, I hate it when you say that. Let's look at these 2. Number 1, this is a cellulitis.
Maintain airway.
Who said that? Very good. Caitlin said that her number 1 priority for this patient would be to maintain open airway. Why?
Because where it's located.
Right? Where? All right here. Right? So, what can happen with cellulitis? Swelling, right? We don't necessarily know that that swelling is going to go out. It can go in, right? And that's real close to that lady's airway or man's airway, whoever it is. That person's airway, okay? All right? So, again, depends, yeah.
Just a random question, is cellulitis blanchable?
Most of the time, yeah. It depends, though. Sometimes it can be really, really, really dark. But it should be pretty blanchable, from what I've seen. I'm sure there's one out there that isn't. But if it weren't, then that would show you that like the degree of injury has kind of progressed, right? Because it's now becoming to a place where it's not blanchable, and if it's not blanchable, it's not getting what? Blood flow, right? And then you have a risk for necrosis, okay? So, and that can happen. What do you think for number 2? What would be your priority for number 2? Okay. Okay. So So we have elevate, we have stop the spread. What else?
Maybe compression.
Maintain perfusion, just like neuro checks on the feet.
Very good, very good. Tommy said maintain perfusion and neuro or neurovascular checks on the feet. Super important. That is a very swollen leg. I'd be worried and making sure that this person has good, strong pedal pulses to make sure that the blood flow is still getting down to that area. With that being said, who do you think is at risk for cellulitis? Everybody. Okay, why the elderly?
They're risk for everything. That's why they're the
Okay.
They may not be able to. Yeah, and, right,
Right, they have bad, go ahead. Right, and they have bad circulation.
Their skin
Right?
has less
Right, so they do. They have, who has seen when an elderly person, like I can bump, right? I can bump right there. Nothing happens. It's scratched a little, right? But what do you think might happen to an elderly person? They get tears, right? Their skin might tear a little bit easier. Also, like I said, they have poor circulation. So getting that blood flow to that area to bring in all of those good white blood cells and everything to the area to help fight against infection, it doesn't happen. What's another group?
young children.
Young children. Why young children?
Because they're running around in the dirt and they're scratching their bug bites, sneezing on them.
They have weak immune systems.
Good.
Usually for LSD as well.
So
Depends how young.
you're right. So infants, right? They don't have the immune system, and then younger kids, they are a little bit more. I wouldn't say that, but they do. Like I said, they'll get a bug bite, they'll scratch it, it opens it up. Right? They're outside playing a little bit more. They get scratches, you know, from this and that. What about if somebody was a diabetic?
Amy. Good job.
Amber said that. She was too loud.
Say it loud, say it proud, Amber. Right? So diabetics have what? What do they have?
Decreased sensation.
They have decreased sensation. They have slow circulation or slowed circulation, poor circulation. Go ahead. Decreased wound healing, right? So that's like it's like this perfect storm for things like this. Okay. Anybody else that you can think of?
Immunocompromised.
Immunocompromised, very good.
Obese.
So the immunocompromised patients also, they don't necessarily have to have like a break in skin integrity because they're immunocompromised, okay? Do you think that if you had cellulitis before, it would put you at risk for cellulitis now?
No.
Yeah.
Depends.
Yeah. So previous history of cellulitis puts you at risk for developing cellulitis. If you have peripheral vascular disease, yeah.
What about other skin conditions? Like
I can see
psoriasis?
that. Yeah, I can see that. So if Christy brought up a good point. Things like even like tinea pedis, that's athlete's foot, right? That can put you at risk for cellulitis. It can open up the skin. Anything really that opens up the skin and anything that decreases sensation and circulation can put people at risk for cellulitis. All right. Does anybody have any questions? Yes?
So, the guy that had the clinical, his was like really, really dry,
Mm-hmm.
and there's like brown, like crusty, like all over. Is that just from like?
It could be it could be from a lot of different things.
He also had PAD, so it's.
So we have peripheral arterial disease.
So, I mean, you're talking about. I mean, I've seen the wet before, but his was just like super dry.
Mm-hmm.
So like, I just.
There, again, the bacteria that cause cellulitis, most of the time it's staph, but it can be a lot of different bacterias. So it could be that, it could depend on the circulation, it could depend on if he had some, type of skin condition already. Yeah.
If they're post-op, are they at a higher risk, or is that like a different kind of like 30-40%?
So the break in the skin would put them at risk for an infection just because you have An open wound doesn't mean that you're going to get cellulitis, but the opening of the skin puts you at risk for bacteria to come in, not portal of entry, so they would be at risk for cellulitis. Yeah. Yeah. All right. Any other questions? All right, guys, why don't we take a 10-minute break? Okay, I've heard infiltrates, I've heard bacteria in the lung, I've heard the word pneumococcal. Katie said you can get it outside, or get it from going outside with your hair wet, old wives' tale. But what happens, like why do people get diagnosed with pneumonia over like a bronchitis? Yeah.
Sometimes it's like aspiration.
Good. So there are a lot of different types of pneumonia, right? So you can hear maybe like atypical pneumonia, viral pneumonia, bacterial pneumonia, ventilator-associated pneumonia, aspiration pneumonia.
Sometimes, not always. You don't always hear
Okay.
sometimes it's through an X-ray.
So those are ways to diagnose, right? Like through X-ray, you see certain things. What's happening to the lung, though? What's happening in there? And that inflammation, right? So it's inflammation in the lung and in the lung parenchyma, which includes like the respiratory bronchioles and then those alveoli, as a result of infection. Sometimes you can get inflammation, right? You can get inflammation in the actual bronchi, and that doesn't mean that you have a pneumonia. The pneumonia is the inflammation and infection of that parenchyma. Where do you think pneumonia lands on the leading cause of death? Where do you think it is? Top 10, top 20, top 50? Top 10? Okay, so let's get it down. Are we talking top 5?
I'll say top 5.
Okay.
Number 4.
Number 4. We've got 4. What else? Not number 1. It's actually number 8.
Close.
Okay, so it's number 8 on the leading cause of death. That tells you how serious this is, right?
I mean, it's not top 7.
And not top 7 serious, right? But still, top 10 serious. 8th leading cause of death. So, we've got this inflammatory response in the alveoli. What's your patient going to look like?
Dyspnea.
Dyspnea.
The obvious one.
What else? Fatigue. What else?
Maybe
Coughing. Very good. Chills, fever, lack of appetite,
wheezing.
maybe some wheezes.
Fatigue.
Fatigue. Very good. May hear crackles. You may just hear diminished lung sounds. You may be listening, and up here, fine, here, fine, right here, real diminished. Like a low bar, lower lobe pneumonia, okay? What about, do people get chest pain? They can, right? They can. What about hypoxia?
Oh, yeah.
Yeah, people can get hypoxic. What about cyanosis? Yeah, they can have cyanosis. What do you think they're producing a ton of? Sputum, right? Mucus, sputum. They may have a productive cough. What do you think that sputum could look like?
Green.
Okay, it could be a yellow, could be a green, or it could be, might be, what else could it have in it? Blood, right? It might be blood tinge, hemoptysis, okay? Who's at risk? Okay, smokers. Who said smokers? Okay, smokers, good.
Young children.
Okay, young kids. Why young kids? What did we say for cellulitis?
No immune system.
Good. their immune system is immature, right? So they have this exposure to all of these different things, and their immune system doesn't have the maturity to fight against it. Immobile people? Why immobile people? Okay, so they might not be taking those really good deep breaths and getting that expansion, right? I don't know, people in my clinical group will hear me talk about when I teach an IS. Katie, what do I say when I teach an IS? About the...
It like pops open.
Yep. And what are they normally? Do you remember?
I don't know what they're asking. What are they normally?
So what are the things at the base, your alveoli? What do I tell people that they are?
Like bunches of grapes.
Like grapes, right? And then what can happen? They shrivel up
They
too.
shrivel up to
Raisins, right? So we don't want raisins, we want grapes because that expands the amount of gas exchange. So like the alveoli at the end of your bronchial tubes, right? Like they're bunches, they're bunched up, right? So I try to tell people that they're bunches of grapes. And we don't want those to shrivel because raisins, same grape, right? But smaller, right? So less surface area for gas to exchange. So if they're not taking those nice deep breaths, right, and they just came out of surgery and they're sitting there and they're breathing like this, what do you think is going to happen? Shriveling. We have got raisins, right? We've got deep hashtag shrivel, right? So we have got an accumulation there, right? And that's where people can get that hospital-associated infections, right? We don't want them to get pneumonia after surgery because they're lying in bed and they're not getting up and they're not moving. Not only putting them at risk for other things, but we're putting them at risk for pneumonia, okay? Who else is at risk? COPDers, okay? So anybody really with like a chronic heart or lung disease is at increased risk. Okay, so maybe you're already fighting something, right? What about alcoholics?
Yeah.
Why do you say yeah?
They just seem to
What's
be a
the...
risk for everything.
Okay. What about their immune
Their
system?
nutritional deficiencies.
Well, they do. They can potentially have that, but again, remember what Dr. Fritchie says, don't go down that yellow brick road. Like there are some of we are talking about infection, right? So let's think about like what do alcoholics have a decrease in?
Liver function.
Okay, liver function. But we're talking about infection. Yeah, you said it. You said it. You were right. So macrophages, right? Those that come and they like Pac-Man. So it's a decreased macrophage action. So it puts them at more risk. All right, we already said smokers, right? That's kind of a... What else? What about elderly?
Of course.
We already talked about in cellulitis, like that poor circulation. Very good. Say it loud, say it proud.
Elderly are more at risk for aspiration pneumonia.
Good. Why?
Because they have dysphagia sometimes, they can have.
So they can. Anybody can really have dysphagia, right? Elderly have a decrease a lot of times in their cough and their gag reflex. So that puts them at risk for aspiration pneumonia. Who else is at risk for aspiration pneumonia? Right?
Infants.
Okay, good. Anybody that has a decreased swallow, right? Yeah, Erin.
Say GERD.
Okay, if they have GERD, because when they lay back, right, and they're laying down, that has a risk of kind of coming up and going over, right? Somebody said a stroke. How about general population? Let's say that I went into surgery and I was not NPO 8 hours prior. Would I be at risk?
Yes.
Yes. Yeah. Okay. And sometimes that happens. Sometimes there's emergent surgeries, right? Now, I come out of surgery and I have a NG tube. Am I at risk? Yeah, right? You're at risk for aspiration when you're on those enteral feedings, okay? How do we prevent it then? Like, how do we prevent pneumonia? What are some things that we can do? Incentive spirometers, very good. What else? So these are our what? Nursing interventions, okay?
Calm people,
Okay?
raise the head of the bed.
Good. Elevate the head of the bed. What about those liquids? Is it easier to swallow something that's thin or thick? Thick. Good. So thicken those liquids if they need to be. Early ambulation. Get them up. Get them. Right? Nice deep breath.
Cough and deep breathe.
Cough and deep breathe. Now, let's say, as far as prevention of spread, we have something that's like a cough etiquette, right? Like, you know, you go to the grocery store and you're like standing by that person at the lunch meat line, and they're like, and you're like, oh,
Cover your mouth.
bless. Like, it's everywhere, right? No. And then here's my favorite, right? The people that like, and they cough into their hand, and then they go in front of you and they touch the thing that you just wanted to touch, and you're like,
Put it there.
really? Like, come on, okay? So how are we teaching people to cough? If you have to cough, where are you coughing? Like that, into your elbow, okay? Preferably with the sleeve on. Yeah.
One of my patients at Purple had like really bad pneumonia. They gave a flutter valve.
Okay, yeah.
So that's something that we should just
Flutter valve. Who is flutter valve? I was like, wait, there's a flutter valve. Okay, so the flutter valves are something that respiratory normally goes over, and it's an order. So who wants to talk about a flutter valve?
Not me, I already talked about it.
Do you blow in or do you blow out? Okay, so here's what, yeah.
I think blow in.
So,
Suck it.
yeah,
And it like, it kind
Right.
of like jostles things around.
right.
Wait, what?
Okay.
You blow. You
Well,
breathe.
I'll tell you what. On break, I will find a picture of a flutter valve, and I'll get it up
You can, like,
on
adjust the
the.
resistance.
Yeah, it stimulates the patient to cough, right? And so it helps them get that sputum up and mobilize the secretions. Okay.
So you breathe in?
I'm gonna try and find one so you guys can see it, because it's so different than the IS, and it can be confusing.
I felt like she said after.
Okay. All right. What else can we do to help prevent pneumonia? Not just in patients in the hospital, but everywhere. Fluids, okay. Why? Because we'll talk about this in a little bit. Help thin stuff, okay?
I don't want to say it.
Good. Vaccinations. What type of vaccination? There's pneumococcal and very good the flu. The annual flu helps to prevent actually getting pneumonia as well. Okay, so, and then the pneumococcal vaccine, all right, it's recommended for high-risk people, if you're older than 65, chronic heart and lung, patients that are diabetic, alcoholics, chronic renal failure, cirrhosis. There's a whole laundry list on the CDC website, all right, that there's 2 different types, right? So there, yeah, and again, like Dr. Pritchett says, like, you know, you don't have to go and like study, like, okay, it's going to be this, it's going to be, no. All right, just know the pneumococcal can help prevent pneumonia, all right? Now, much like our patient with MRSA, right, and you go in and you've got that big old, like, stop sign when you get going into the room, and they're on contact precautions, what could your patient potentially be on? What type of precaution? Droplet. Yep, droplet precautions, okay? All right, so now that we know that our patient has pneumonia, look at this poor soul. Right? I mean, they are miserable.
Lungs, I thought it was like.
Yeah, no. Miserable, right? Those are bugs, right? They're bugs, okay? I mean, this poor person does not look like they're feeling well at all. Okay? Cough. All the things that we talked about. Cough, fever, chills, tachycardia, tachypnea, dyspnea, all the others. Pleural pain, malaise, respiratory distress, decreased breath sounds. Some of those are just the opportunistics that most people won't get, like the PCPs and stuff like that. But look, yellow, blood streak, rusty, sputum, ew, right? These people are sick. So it says doctor's orders for diagnosis, sputum culture, chest x-ray, ABGs. You guys talked about that with Dr. Schlereth. There's that sputum culture. Patient has a fever, coughing. Did everybody get that? Or you want me to leave it up for half a second?
Leave it up.
Okay. You ready? All right, so in your groups 1 through 10, I want you, pharmacologic therapy, I want you to focus on that. What are your interventions and what do you hope to accomplish from the intervention? All right, so think about some of the medications that your patient with pneumonia might be given. All right, again, you don't need to go like all astray, just think normal, what would they might be given. You don't need to know specific antibiotics, okay? There's nothing listed for, it's just gentamicin. Again, just know that certain pneumonias might have different antibiotics depending on what type of pneumonia it is, okay? If it's outpatient pneumonia, it might be one thing. If they think it's drug resistant, then it might be something different, a heavy hitter, okay? Then your non-pharm therapy. So what are your interventions? What do you hope to accomplish from this therapy? And what I mean by that, like, what is your patient going to look like after the therapy? If you're talking about a medicine and you administer it, what do you hope the patient is going to look like after administration of that medication? Okay? So let's take like 10 minutes and do this in our group, and then we'll report back.
So it's just the medication.
Talk to me about one of your pharmacologic interventions.
So an expectorant to kind of get the mucus up and out.
Okay, so there was one of those on your list.
How about you pronounce it?
Guaifenesin. Okay, guaifenesin. All right, so it's a common ingredient in expectorants. What does guaifenesin do?
It reduces the viscosity of the secretions.
Good, Amy, say it loud, say it proud.
It reduces the viscosity of the excretions.
Good, so reduces the viscosity, helps break up that mucus, decrease the viscosity. What do they tell you to take it with? What do they tell you to do with guaifenesin? Like if you have, a pill or a liquid, what do they say? No, not a probiotic. That would be more for antibiotics, right? Sometimes they may say, okay, you're on an antibiotic. It's going to be a little lengthy of a time. Take a probiotic. Some people would tell you that. Okay, let me give you this analogy. What do you take it with? For anybody that has kids, right? It's August, and you get that dreaded school list. It's like this long, and you're like, why does my child need 42 pencils? Okay? And you're thinking to yourself, what can I take from last year, that I could potentially send my kid to school with so I'm not buying 42 more pencils? And you go in there and you're like, glue. They never use glue, right? And your kid happened to have that liquid Elmer's glue, and so you go into your cabinet and you get it like, yes, like this is a full thing of glue. And you open it up and you're like, and nothing comes out.
You're a better mother than me.
Because it's what? It's dried up, right? Like it's been sitting in there since Lord knows when, all right? And it's all thick, okay? It's all thick and whatever, and you go to shake it out, and you're like, huh. But work smarter, not harder. So what are you going to add to that? A little bit of water, right? Because what happens when you add the water? Say water. What happens when you add the water? Okay. It thins the glue. That is just like the secretions in people's lungs. If they are dehydrated, those secretions in sputums get just like that glue that has been sitting up in your cupboard for the last year, and that you want to add water to so that you can save a couple bucks and not have to buy it again. That is exactly what hydration does to those secretions in somebody's lungs. It helps to thin those secretions, and what do you think? Like you get that glue and it's like you can't even get your fingers out, and then you put water and it's like, oh, this is nice. I can move my fingers around. They can cough it up. They can expectorate it, right? just what guaifenesin does. So a lot of times if you look, it will tell you to drink a full glass of water with guaifenesin to help thin those secretions out. Now, if it's a liquid, something that you want to be careful with is that sometimes it has alcohol in that suspension. So people that are on like antabuse, they probably don't want to be taking something like that. Okay? All right, so guaifenesin, need to know drug, guys. All right? What else? Group number 7. Tell me another pharmacologic therapy. Good. Oxygen, right? So they might be on a little bit of oxygen. If they're tachypnic, if they're slightly hypoxic, oxygen therapy. You might see them on a nasal cannula. You might see them on a face mask, on a non-rebreather. They might be on a Venturi mask. Some people, pneumonia can get so bad that they're intubated. All right? The intubation? What do you mean? Oh, you're thinking like the exposure to potential bacteria through the intubation? Is that
the lungs not working for themselves?
so? But at the same time, if they're not oxygenating, right? If they're not, if there's so much mucus, they need help. Like they need help oxygenating. So that's why you intubate them.
How would you get that too sterile though, especially if you're going down through all this like inflammation or mucus?
But have you guys ever seen anybody intubated?
On TV.
Okay, is it a sterile process?
No.
Nope. But we are going to talk about something in a couple of minutes called a bath bundle. So when people are intubated, there are bundles that a lot of hospitals have that are there for nurses, respiratory therapists to do to help avoid ventilator-assisted pneumonia. Okay, so we'll talk about things like mouth care and chlorhexidine mouthwash. I had, it was in clinical, somebody said, oh, I did some mouth care. Right? Like, well, I did something, I did some mouth care. And I'm like, that's awesome. Like, mouth care is a huge thing. It is such a big thing that they put it into these ventilator-associated pneumonia bundles because this is a very big place. Right? But, yeah, when they don't want to brush their teeth. But still, the mouth is very dirty. So this is all part of the tract, right? So if this is clean and we're decreasing the bacterial load in your mouth, we can hopefully decrease the bacterial load that could potentially get down into your lungs. Okay, what else? We've said oxygen, we've said guaifenesin. Number 4. What's another one?
We said, a couple things. Bronchodilators.
Good, very good. So bronchodilators, what would be a common one? Albuterol, right? Yeah. Did you have a question? Or? Ipratropium?
Yeah, there we go.
Okay, yep. There you go. Yep, so bronchodilators, that helps helps bronchodilate so that you have more area for the air to go through, right? So it's not all from inflammation. Good. So Preventol, I think you guys have learned Preventol. Is that right? Yeah. So some people do get steroids, right? It's inflammatory, right? Exactly. So some people may get steroids. Some people in outpatient may get steroids as well. They may get like a, couple days worth or something like that. But yeah, they might get steroids. They might get either a systemic or they might get an inhaled steroid. Yeah, there's Advair. Advair will be one of them. Could be. Okay. What else? Number 8. What's another thing?
Antibiotics.
Very good. Very good. Antibiotics, right? We're going to give these antibiotics in the hopes to decrease the cause, right? Like we are getting at the reason that these people have pneumonia. Okay? Anything else? What if they have a fever? Antipyretics. Good. Okay. All right. What are my non-pharm groups? Let's see. Number 13. 13? Lucky 13?
So that would be instead of spirometry.
Okay, good. Incentive spirometry. What is the goal? Like, what do you hope to accomplish with your patient with the incentive spirometer?
Keep the grapes.
Keep the grapes. I like it. Good. Yep. So it's really helping to promote that deep breathing, coughing, and then the clearance of secretions, right? Okay. Group number 19.
I'm the only one here.
Okay. Do you want to phone a friend?
Yeah.
Okay. Group number 18. Help her out.
Flutter valve.
Flutter valve. Okay. And I will.
Clear up that mucus.
Yep. I will get a picture and put that up there for you guys. Okay. What else? Number 17. Yep.
We're 20, but,
Okay.
postural drainage.
Good.
To help expectorate and promote their comfort.
Very good. So we're actually going to do some postural drainage. And there's something else that can go along with that is what? Yeah. Good. So chest physiotherapy. You'll hear people say chest PT, right? And we're actually going to do that too. Okay, so you guys can see that. All right. What else? What are some other interventions?
Positioning to promote oxygenation.
Good. Positioning. Just certain positioning, right? So people that lie down, that are lying down in bed, where do you want the head of the bed? High phallus, right? It helps them expand that lungs. People sometimes will be proned. Has anybody ever heard that? Because you're lying supine all the time, and that mucus can go back. And even in the ICUs with intubated patients, they will prone them and flip them and lay them on their bellies so that the air can move and everything can kind of move around in a different way. So patients, really important to get them up and into the chair. Really important to get them up and ambulating, okay? It moves things around. What else? Number 11. Yeah, go ahead.
They're teaching them how to effectively calm.
Good. Making sure that they're actually doing a good cough and deep breathe. The flutter valve can help with that. Okay, yeah. Suction. Okay, sometimes people might need a little bit of help getting that out. What else?
Fluids and adequate nutrition.
Fluids. So these people need 2,500 to 3,000 mLs a day.
That's a lot.
Again, asterisks, right? Unless they're on some type of fluid restriction. Okay. But in general, we want to increase the fluids. Again, remember that glue. What about meals?
More calories.
Good. Yeah. Very good. Small, frequent meals. These people are tired. They are working, okay? They are working to breathe. So small, frequent meals. What about rest and activity? Balance it, right? So balance your active times with some rest time. You don't want these people to fatigue, okay? We could do sputum cultures, right? Let's say that this patient says, every time I cough, it hurts. They've been coughing and coughing and coughing. What can you give them? Okay, so they might get some analgesics, right? But what else can we do? That might help, maybe. Okay. What could they hug?
Oh, pillow.
Pillow, right? They can hug a pillow, yeah. So sometimes, that's great. Sometimes they actually do a bronchoscopy to help go down. They'll do it for two reasons sometimes. Sometimes to do the sputum culture, they'll get sputum from that, and then they'll send it off. And other times they do it in conjunction to actually get some of those secretions out. They'll go in and just clear it out, okay?
So is that a test or what?
It's a procedure. It's a procedure, yep. All right, what if the patient comes in and they are a smoker? Yeah, it's never good, right? All right, when do you call the healthcare provider? What is your something ain't right moment?
After 24 hours when that seems sensitive.
Good. Good. Temperature spike. Their fever increases.
SpO2 dropping.
Okay, good. What about if the patient, you came in and they were slightly confused than they weren't before?
That's not good.
I will call. Increased confusion, Decrease, okay, yep, decreased level of consciousness. What if before they got up and they were able to walk to the bathroom and ambulate, they're a little tired, right? They get back to the bed and they're fine. What about this time? They can't even make it to the bathroom. They have worsening activity intolerance. Alcohol. Okay? What about if they started having difficulty breathing, increased shortness of breath, fatigue, increased fatigue, if they were increasingly sleepy, increasingly tired? Okay, we're going to watch a quick video mechanically. So people might actually have a vest that they apply, and that does the chest PT for them. When I think of that, I think of kids with cystic fibrosis, where it's more of a chronic thing that they're trying to accomplish. So what do you think we're trying to accomplish with chest PT? What are we trying to do? Right, so we're trying to reduce that consolidation, prevent atelectasis, okay? So I'm going to, Professor Keller has a mask from an ambu bag. So you may see it done this way sometimes, especially in peds, right? They teach parents how to do this. You'll notice that the actual hole is taped up, okay? The cupping of like that, or the cupping of your hand, allows air to get in there, and it helps prevent injury. There are certain places that we do not want to bang on. Where do you think we're not going to be banging on? Okay, so breast, sternum, spinal cord, over the kidneys. Okay, so you want to really avoid that area. You do need an order. Okay, you need an order for postural drainage, and you need an order for chest PT. Okay? So in the picture here, this nurse is performing percussion, and this is vibration. Okay? So I'm going to have, do you want to sit this way so they can actually see your back, like face that way? Okay. So you take your hands, and you don't want this sound. All right? This is not the sound. You actually want to hear, it should be a hollow sound, so more like, you guys hear the difference? Right? Now cup your hand like this, okay? Thumb in, nice and cupped, it's kind of rounded, and then you're just going to you might see people do this. They might go, okay? Make sure it's nice and hollow like that. And then Professor Keller's actually going to demonstrate with like an ambu bag, okay?
You just kind of hurt.
Yeah, it doesn't hurt. And that's why you cup your hands. The trapping of the air actually helps so that it doesn't hurt. So what I want you guys to do is to get a partner and practice. Okay, we're going to walk around, all right, and then we're going to do some postural drainage, okay?
Hit me.
How I should be posturally drained, okay? So postural drainage means that we are moving the body, okay, in a certain way so that airflow is different and better, and so that those secretions are mobilizing, okay? Are you ready? How much below?
So how should she be positioned if there's a consolidation in the posterior middle of the right and left lung?
So back here.
How should we position?
Who said prone? That's good. So I would have my patient with a pillow here and then underneath their legs, and your patient would be like this. Okay?
And then it's posterior right and left lung.
Okay? That's how it sounds. All right, so this is what it's going to look like. See here? Posterior, so then that means that they're up. Okay? Oh, you have it. That's right. Okay, good. Right next.
All right, next is anterior bottom of left lung. How should she be positioned?
So this side, where would I be? On your right side. Okay, so I'm going to be lying. Where's the pillow going to be? So I'm going to lie on my right side. Right? Where's this going to be?
Under that.
Okay.
So here.
You look pretty comfy right now.
Yeah. Now what about my feet? What would you do to my feet to help raise them up? Okay, so they may be be raised like 18 inches. Probably.
Those are cute shoes.
Okay. All right, so you'll see here, and that's for like the whole bed, right? The bed's tilt, okay?
And then lastly, if she had a consolidation anterior bottom of right lung, how should she be positioned? Anterior bottom of right lung.
Opposite.
Good.
And on the other side. And
Yeah.
reverse treatment.
Put the feet up.
Okay. Right? Okay.
Nice pose.
Is that considered reverse trauma?
They
So
have
if it's
tables in
both
hospitals,
anterior, then would you just be?
So the table will move.
Yeah.
Tables can tilt down, can tilt up. There's actually in some hospitals there's tilt tables, and they stand patients straight up.
Oh, I did see that.
Nope. Okay.
These guys are commercial. For like retired EMT person.
Thank you. All right. So what are we using with postural drainage? What's the main thing? Gravity, right? So it's gravity to facilitate removal of the secretions. The patient is positioned with the segment to be drained superior or above the trachea and main stem bronchi. Okay? So the book has a lot of different positions and this way and that way. Okay? It's important to have an idea so that you understand that that lung to be drained, that particular segment that's positioned with a segment to be drained superior or above. Okay, we're using gravity to mobilize that those secretions. All right. So, would you give somebody a bronchodilator before or after postural drainage? Before, right? Open them up. Help move that stuff. What about eating? Would you tell them to eat before or after? After. Okay? After. Good.
Or else you're draining everything.
Yeah. So it really helps to avoid the nausea and the vomiting. Okay? All right, next. Does everybody have their case study? Yeah, the chest x-ray would show where that consolidation is. Yep.
I think she left.
But yeah, like I said, you didn't order. Because didn't she go to daycare? Yeah, right? Okay, so she's got a young child coming in that's exposed to a lot of different illnesses and bacteria, okay? What else? Does he have lymphedema? Yeah. Okay, yep, he sure does, yep. What else? Somebody said he worked on automobiles, retired mechanic. Okay, he probably has exposure to some things that not everybody has exposure to. So he comes in, he gets admitted, you've got your admitting orders, okay? Everybody look at those orders. All right, here, answer a question. Which finding would you expect when assessing Mr. Archer? So we're talking about expected findings, okay, for this man. Do you think deviated trachea? Hopefully not, right? What's a deviated trachea associated with? Pneumothoraxis, okay? What about B?
Yes.
Sure.
Okay. What about C?
Yeah.
Potentially, okay.
That's not good.
Okay. Oops, hold on. So the answer to this one is B, okay? C, wheezes are more associated with asthma, all right? Not so much with pneumonia. You may hear it, but as an expected finding, we probably wouldn't hear that, okay? You may, again, you may. So when you go to clinical and you're like, Professor Barker, my patient with pneumonia had wheezes. You're lying to me. You're telling me lies. No, they may, okay? But most of the time with pneumonia, we wouldn't necessarily think, unless they have something else, okay? Maybe they're a COPDer that is having an exacerbation and pneumonia. You might hear some wheezes there, okay? What do you guys think about the pink tinged sputum? Okay, so we talked about hemoptysis, right? Potential hemoptysis, which is blood tinged sputum. When I hear pink tinged sputum, I think of like pulmonary edema, that type of thing, maybe caused by a heart failure. I know you guys haven't learned that yet. I think you guys do heart failure in third term. But that's what I think of as pink tinged sputum, okay? But this increased respiratory rate and use of accessory muscles, I think that that might happen to this man, right? He has this emphysema. He's trying to what? What is he doing by? He's compensating. Very good. He's compensating, okay? So he's compensating for this ineffective exchange of oxygen, carbon dioxide. Okay. Look at this next one. These are your guys' favorites. So select all that apply. Right? Everybody loves these. Okay, so I want you guys to read the question. Mr. Archer's oxygen drops to 88%. His oxygen is turned up to 4 liters nasal cannula, and currently his O2 stat is back up to 90. What additional nursing interventions are most appropriate? So I'm just going to throw all these up there. Select all that apply, okay? Don't call them out yet. Let's get them all up there. Okay. What do you guys think about A?
No.
No.
Why not?
Because our orders are for, we're allowed to titrate between 2 and 4 liters to keep the oxygen stats between 90 and 92.
Very good. So the orders state to titrate between 2 and 4 liters for 90 to 92. Good.
If at 4 liters we weren't maintaining that, that would be cause to call the doctor.
I would call the doctor then. I would call the doctor. And that's not something that you're not going to tell them, but you're definitely going to report an S-bar to the doctor. Hey, we did have to increase the oxygen from 2 to 4 liters, you know, and he's maintaining now at 90. All right? You would definitely let them know that, but that's not a something ain't right, I need to call right now moment, okay? All right, what about monitor the client's respiratory rate?
Yes.
Yes. Yes. How about provide the client with sedation to help him rest? No. I wouldn't do that. What about D, monitor the client's SaO2?
Yes.
Yes. And what about the client's inhaler as ordered?
Yes.
Very good. Yep, those are all things that you would do, all appropriate for nursing interventions for this particular client. Again, I would encourage you guys, take a look at that. I think that those things on My Nursing Lab are great. Yeah, that's it. As far as questions and stuff like that, again, get your minds going, okay? Yeah, I was about to say, do you guys need a 10-minute break? All right, and then we'll start with UTIs when we come back, okay? Okay, so urinary tract infections. Where do they happen?
Urinary tract.
Anywhere, right? So when somebody's like, I have a UTI, very broad statement, okay? Because look at this whole, could be anywhere along there, okay? So it's a very broad statement. Why do people get up?
Bye, Felicia.
Why do people get urinary tract infections? What happens? What are some reasons? Unsanitary? Okay. Let me ask this first. Is this tract sterile?
We make it now.
Okay, so we've got some yeses and some nos. Who says yes, it's sterile? Okay, why?
Because it is.
Okay, but I need a why. There's always a reason. Why is that sterile? If you say yes, why is it sterile? Why is the whole tract sterile?
If it wasn't sterile, like constantly have a UTI.
Okay.
Filtered out.
I'm sorry?
Filter out by like the kidneys.
Okay, so Caitlin says that the kidneys filter it out. Tommy says because.
He said because coffee maker.
I said because the kidneys are like a coffee maker.
Oh, okay, because the kidneys are a coffee maker. Okay, I like it. I like it. What else? So the whole tract.
It's the closed system.
Okay,
At the end.
but is it closed?
No.
Except at the end.
Except at the end. So the tract is sterile except for normally a small portion of the urethra. Okay, that's not sterile. So really, bacteria shouldn't be living up in there, okay? What is this? Here, a picture of.
Urinary bladder.
Okay, and that's your ureter, right? So here, ureter, bladder, kidneys. Which way does the urine flow? Which way should it flow?
Down.
Downward, right? What do you think would happen if this did not close? What could happen? Backflow, right? So backflow can happen, and that's vesicoureteral reflux, VUR, okay?
Is this a need to know?
As far as, I mean, you should know what VUR is, yeah. Because you may hear it, like it could be a cause, right? It could be a cause of urinary tract infections, okay?
Can you say it one more time?
Vesicoureteral reflux. So this should close when you void so that nothing goes back up into the ureter. Okay? Right? So that's where, yeah, that's why I put both of them, that's why I put both of them there. Bladder, ureter, okay? Why else do people get urinary tract infections? So we've got this backflow, right? Why else?
Urinary stasis.
Urinary stasis. Who does that?
Everybody.
Right? Like, we're the worst. Like, people are almost proud to be like, I don't go once during my 12-hour shift. It's like a badge of honor, right? Like, it's cool. I only need to take a break once. But they really say that you should void every 3 to 4 hours. Okay? To flush out the system. Stasis can cause bacterial growth. All right?
They need meds, and they have questions, and they have...
So being dehydrated causes a UTI, or is that more of a UTI?
I would think more of the caliculi. Hydration status is important because we want to flush things out. Like, we want to keep things
Would the
moving.
dehydration lead more to like the urinary stasis, not voiding frequently enough?
I can see where dehydration, if your bladder wasn't filling and you didn't feel the urge to go to the bathroom and it was stagnant, yes, but I don't know that dehydration is, yeah. I think, yeah. I would think so. So stasis, yeah. What else?
Patients that have frequently straight cat themselves.
Okay, straight cats, right? Like anytime that an instrument, all right, instrumental introduction into the urinary tract, all right, yeah.
Poor hygiene, like wiping back to front to introduce E. coli.
Very good. So poor hygiene. So in women especially, they should be wiping front to back and not back to front. Back to front is introducing E. coli into that tract and into that area. So what else could be? With that in mind, what else? Sex is a very good one. Okay, so sexual intercourse, especially if they have the use of spermicides, diaphragms, cervical caps, okay? Or condoms even, it alters the vaginal flora, okay?
Why don't more kids in diapers get UTIs?
So we'll talk about that when we talk about lifespans. There's actually kind of a switch from like boys to girls, and if there's not proper hygiene, then you can have risks for urinary tract infections in infants. But that is one in adults. So bowel incontinence, right? All in the neighborhood, okay? So bowel incontinence is one. Going back to the sexual activity, if you have a history of urinary tract infections, it's not recommended that you use a diaphragm. So just kind of a... We talked about voluntary retention of the urine, okay? Who does this sometimes? Not just nurses, right? We've covered that. Kids, right? Kids will sometimes hold their bladder. Sometimes they see it in school-age kids if they don't want to go potty at school, right? Okay? Neurologic. Okay, so neurologic, right? They might have some type of functional incapacity where they can't actually get to the bathroom, so they're incontinent. But also there's something, diabetics can get this. Spinal cord injured patients can get this. You'll talk about it next week, Professor Keller. It's neurogenic bladder. Okay? So that's where the innervation to the bladder is compromised in some way. And so then they don't know that they have to go to the bathroom. These people might have to be straight cath, or they get urinary tract infections because of stasis. Again, they don't get that urge to go to the bathroom. Okay?
And what populations did you say again? Diabetics?
Diabetics, because they can get peripheral neuropathy, right? It's not specific. Like the neuropathy doesn't just go to the toes. It can go anywhere. Yeah?
Can't antibiotics also give you UTIs?
They can do, I'm thinking yeast infections. Yeah. Yeah, I'm thinking more yeast infections. Yep. Or C. diff, yes. Okay, what about, somebody set it up here. What about a caliculi? A blockage? What's that going to stop? The flow, right? Like that movement of urine, okay? BPH, very good, because that's obstructive, okay? What about, if you were to put up here a male and a female, which one do you think? Average adult, let's not take into like older, younger, whatever, just average 35. Well, that's average for me, maybe like 28, something. Or a female or a male. Who's more at risk?
Women.
Why?
Anatomy.
Very good. Women have a shorter urethra. Okay, look at the difference here, right? Here to here. It doesn't have as far to go. Okay? So now we know like who's at risk, what puts people at risk. What are we as nurses going to tell them to help prevent urinary tract infections? What are some good? We talked about some stuff. We talked about the front to back for women. What are some other things? Caitlin?
Increased fluids.
Good. Encourage to have to maintain a generous fluid intake, right? That 2 to 2.5 liters a day. All right, it's good. Shelby? Yeah. Good. Go to the bathroom. Empty the bladder every 3 to 4 hours. Okay? What else? Yeah. Good. So things like, oh goodness, like caffeine, diet drinks, those types of things. What about avoiding other types? Like we're talking about what we can do, but what else should we avoid? Maybe it's a diuretic. It might help flush something. That would be more for like a stone. Again, no yellow brick road, just your UTIs. Like let's just UTIs. What will we tell people to avoid? Think about women in particular. What are we going to tell women in particular to avoid?
Diaphragm.
Okay, maybe. Not the end of the road? Okay, so you have a woman and she comes in and she says, oh, I have really painful urination and I have some foul-smelling urine, and you start questioning, do you do this, do you do this, do you take bubble baths? And she's like, I take a bubble bath every night.
Oh.
Bubble baths. I know, I'm trying to get you down the road. We'll get you down the road. So what else would you tell women to avoid with that in mind?
Hot bathing suits.
Okay, so hot tubs, perfumes, wet bathing suits, more for like yeast infections, for like vaginal sprays, douching. What is that changing?
The pH.
Changing our pH. Okay, so you're changing the vaginal flora. That vaginal flora is good flora, okay? It helps prevent bacterial growth, all right? Tell women to wear cotton underwear, all right? Cotton underwear is breathable.
Pee after sex.
Pee after sex, I like it, okay? After sexual intercourse, flush out that bacteria. Okay. Anything else we can think of? Somebody said caffeinated drinks. What are some other drinks that you might want to avoid? If you had a urinary tract infection, yeah. Okay. Alcoholic beverages, yes.
She just said no
They say citrus juices sometimes, but then they say definitely like cranberry juice can help. Okay. All right. So.
Oh my goodness. Yeah. Couldn't handle my lifestyle.
So,
extra stressor in my life. Good for you.
We talked about, guys, I know we're almost done, okay?
No, we're
Deep
not.
breath. We're coming down the home stretch, okay? I know it's been a long day, all right? I know it's been a long day. What's the difference between cystitis and pyelonephritis? Does anybody know? Remember we talked about UTIs in general, whole track.
Pyelonephritis would be
Okay.
the kidney infection.
Okay, good.
Sounds good
And what
to
about
me.
cystitis? Good. Very good. So, how do you think those people would present? Do you think they're going to present differently, or do you think they're going to be exactly the same?
The kidney might have flares, the bladder may not have flares.
Okay, so Katie says that the pyelonephritis, they may have some flank pain. With cystitis, they probably wouldn't. With pyelonephritis, do you think they're going to have fever, chills?
Could, yeah.
They could, okay. So they might have dysuria with cystitis. They could have it. I want you guys to take a look at this picture, okay?
Leave that up for a second, please.
I will leave that up for a second. Urgency. Yep. There you go. Or frequency.
Suprapubic pain versus
So remember what I said, urinary tract infections, it includes that entire tract, right? Anything along that tract can be infected, okay? So lower UTIs are like cystitis, upper UTIs are pyelonephritis. Mm-hmm.
Cystitis is lower.
Oh, I'm sorry. Yes, cystitis is lower. You're like, wait a second. Yes. Cystitis is lower. Pyelonephritis is upper. Sorry about that.
So, question, kind of for like testing purposes. Like with COPD, like it's kind of broken down like chronic bronchitis, emphysema. Is for infection, are you going to kind of separate, are UTI going to kind of be as a whole, or are they going to be broken down?
So just like any other question, what you need to know will be in the question. Okay?
Wait, what did she ask actually?
She asked if, like, for COPD, there was, like, chronic bronchitis and emphysema. And do you guys need, like, would it be all lumped in together on the test, like COPD? My response to that is just like with any other test question, whatever you need to know will be in the question. Okay? Does everybody have that down? Great, okay.
Put back in my phone, like, okay. No.
Okay. We good?
We're good.
Okay. So cystitis, bladder, right? Pyelonephritis,
Kidneys.
uppers. Okay, so your kidneys. Which one do you think could potentially be on IV antibiotics? Most of the times, pyelonephritis, they may have IV antibiotics. These people can be really sick. Okay, they can be super, super sick. They may transition them then to an oral antibiotic, but sometimes they are sick and sick enough that they'll be put onto an IV antibiotic. Why do you think that is? Like why would you worry a lot with pyelonephritis? What's involved? The kidneys, right? So your kidneys are really sick, and we learned last time your kidneys are super important, okay? All right, what do you guys think? Has anybody heard the term CAUTI? Okay, so what's a CAUTI? Good, catheter-associated urinary tract infection. So, has anybody seen in the hospitals where they have like CAUTI criteria? There's like criteria for insertion. There's criteria for like bladder training, bladder scanning. Yeah.
I know at my job we do, I think it's you claim the first one for bladder training.
Okay. Okay. I think just to know that like there are criterias. Hospitals are not getting reimbursed for CAUTIs. Okay, so think of the things that can kind of the sequelae of that, and hospitals don't get reimbursed for those. So they have all of these criteria now that like, all right, you know, the Foley has to come out within X amount of hours, they have to void within X amount of hours, they're going to be bladder scanned, all of these different things, because they're really serious. CAUTIs are really super serious, okay? All right. Let's talk about lifespan stuff, okay? What do you guys think about older clients? Do they have classic symptoms, or do they have not so classic symptoms? Okay, so everybody knows with like, you know, older patients, older adults, that they may have a change in mental status, okay? That's pretty common. I've heard a couple of people say it. They might have a couple of other things too. Let's say you had a patient and the daughter came in with them and said, you know, she's always gotten up and gone to the bathroom, and the past 2 nights I've noticed that she's wet the bed. Mom's wet the bed. Do you think that would be a sign or a symptom?
Sure.
Nocturia. Yep. So she's incontinent, right? She's going to the bathroom in the night, whether she's getting up, she's incontinent. Change of behavior. Maybe she's the nicest woman, and all of a sudden she's really just been kind of nasty. They might be confused. They might just not want to eat. They might have a loss of appetite. They're just not feeling right. They're not feeling well. They might have a fever. They might not have a fever. What about with newborns? Who do you think is more, so between boys and girls, for urinary tract infections, do they occur more often in boys or more often in girls?
Boys.
In newborns and boys, right? There's a structural kind of issues that can happen, so it's more prevalent in boys when they're newborns, but as they grow older and into older infants and children, it's higher in girls. Okay, I need a couple of volunteers. Anybody? couple more. Anybody? I can just in and out. Okay. Get one. Oh, somebody in the back.
Ew, Amy. Y'all know what I'm talking about.
Make sure you pee afterwards.
Yeah.
Just for show.
All right, so if you have a piece of paper, come on up here. Please, come on down.
So why is it boys is it higher in boys again?
It's a structural. It's structural.
When they have like the shorter urinary girls, it's the structural difference in.
It's like those big solids.
Okay. Well, that's what I was thinking. It's like.
Okay, so we have, these are priorities. So you have a patient with urinary tract infection, and the first one says impaired urinary elimination, risk for infection, impaired skin integrity, deficit of knowledge, urinary retention, risk for shock, and excess fluid. So what I want you guys to do is think about your patient. You know that they have a urinary tract infection. So how would you prioritize these? They're in the hospital, okay? Help them out, guys. You can tell them where to move if you want. So let's make closest to the projector towards me is first.
I think that impairs skin.
They've already got
Skin integrity.
They have it. Yep, they have it.
Nobody cares about skin integrity.
No, I would say that's not knowledge.
I think not, yeah.
Well, risk for further infection somewhere else.
Definite.
You think, John?
I was too.
But skin integrity for incontinent.
That would
I think
need to
excess
move
fluid,
up.
yeah.
Yeah.
Urinary retention is.
I said excess fluid bladder should be last.
Ellen, you should probably go to the end of the line. Sorry.
Urinary retention is excess fluid.
Exactly.
Prevent further infection, like if they already have an infection.
Like if it's not in their kidneys yet.
So just because they're up there doesn't necessarily mean that it is a priority. Remember that too. So you can tell people I don't think you would be in my priority.
Skin integrity because
You're dead to me.
I don't
Like
think
your
that's
nursing
wrong.
priorities, like what you do in clinical, right?
But
You
if
get
they
that patient,
pee
they have a urinary
and you
tract
don't change
infection,
them.
you go in, you
But you're
assess
talking about like
them,
regular adults.
right?
We're talking about
And you say,
UTIs,
okay,
so
these are my
that's
nursing
I don't
priorities
think
for the
that'd be
day.
a risk.
This is what I'm gonna focus on for today.
But how do we know it's like not an older adult? Yeah.
Now you're thinking too much into it.
I'm
That's
not.
thinking about UTI.
I think urinary elimination is first.
Like, are they
Alright,
bed
well,
bound?
Kim says get rid of the deficit knowledge. Who agrees?
No.
No.
You get reoccurring.
Education.
Okay, so how about, what do we always say about discharge? It starts upon admission, right? So let's just say, for argument's sake,
I think that's
you have a woman and she says, I don't know why I keep getting these urinary tract infections, right? I have no idea what's going on. And then she starts telling you this laundry list of things, and you're like, what do you mean you take bubble baths? What do you mean you douche? What do you mean you wipe back to front? Okay? So, again, all dependent, right, upon your patient. So it could be a deficient knowledge or a knowledge deficit that could be the priority for you that day. Because that patient is going to continue to get urinary tract infections if she does not change some of those lifestyle things, okay? So we already talked about that. You can go ahead and sit down. You can sit down. Yep. So.
What? I don't know.
You can sit down. No. You say. You guys say just yet. All right. So, Gretchen, come forward. So, impaired skin integrity. Do you think that would be on your priority list at all?
No. If they're incontinent.
Thank you. Katie says I need to know more about the patient because that might be really high on your priority list if what? They're incontinent. Right? So let's say that this is our older woman who came in with her daughter and now she's admitted and she's incontinent every night and that's the only time that she's urinating large amounts is at night because otherwise during the day she doesn't like to get up, she goes to the bathroom, she's, urinating small amounts because it's painful, all right? So that might be for that patient something that's really important and bump up on your list because like we like to tell you, and you guys don't like to hear, it depends on your patient that day, okay? You can go ahead and sit down. Okay, so let's look at impaired urinary elimination and urinary retention. You guys can both come forward.
To make sure they get every hour.
So, you have a patient that is a diabetic and comes in and their white blood cell count is spiked up and they say you have a urinary tract infection, you landed yourself on the acute care floor and you have a Foley.
Risk for infection.
Okay? So, impaired urinary elimination and urinary retention. How do you think those two go together for that patient? Foley, diabetes.
Sensation.
What are you thinking?
Risk for chronic.
Greater risk.
Very good. Allie said it, okay? So with diabetes, you can have a neurogenic bladder. So this patient could have urinary retention that led to the impaired urinary elimination. Okay? I'm sorry. Impaired urinary elimination that led to the urinary retention. Okay? For diabetics that have that neurogenic bladder that don't feel like they have to go to the bathroom and then that bladder extends and extends and extends and it's getting bigger and bigger and it's fully distended and then they can have something that's called overflow incontinence so people think that they're peeing or they think that they're peeing but really it's that balloon that is so big and it can't take any more pressure and the urine is just coming out. They've had stasis which puts them at risk for a urinary tract infection. So the Foley has been placed, which puts them at risk for what? Further infection. Okay, so that might come up on your list because of the Foley catheter. Okay? Now the impaired urinary elimination, if people have dysuria and it hurts to go to the bathroom, they might have that no matter if they had diabetes or not. Okay? For a diabetic patient, it might not even burn. That might not be a symptom, burning, right? Because they don't have that sensation. Okay? You guys can go ahead and sit down. Risk for infection, you can sit down. All right, what do we think about excess fluid volume? You guys too worried about that? Okay. But again, road, right? Urinary tract infection, would you be worried so much?
No.
If it impaired kidney function?
Yeah.
Right? Okay, probably wouldn't be. Again, dependent on your patient. Okay?
If they're peeing okay, then I wouldn't be too.
You'd still be looking at some of those labs that we talked about. Okay? What about risk for shock?
Urosepsis.
Urosepsis. Very good. Again, we will talk about sepsis next week, but urosepsis is definitely high on the priority list, so look out for that, especially, like I said, in those older people where their signs and symptoms aren't necessarily like classic. They're not blaring in the face. Okay? All right, guys, you can sit down. All right, so what are we going to do for these patients for a UTI? I want groups 1 through 5 to explain a midstream clean catch. Okay? It's one of your skills for this week, so you're going to explain a midstream clean catch. Groups 5 through 10, I want you to list out interventions for management of pain. Groups 11 through 15, interventions for patient education. And then 16 through 20, interventions for effective urinary elimination. Okay. All right, 1 through 5, midstream clean catch. 5 to 10, management of pain, and that can be farm or non-farm, okay? 11 to 15, interventions for patient education. 16 to 20, interventions for effective urinary elimination. So let's just take 5-10 minutes and go through that, okay?
So besides pain medication.
Heating pad.
Being mad?
Heating pad.
Oh, heating pad.
At your actual listed, like, diagnostics or skills is not on there. You do not need to know a nose and throat culture. Okay? It's actually like within your objectives. It's just not listed on the,
It says in-class activities.
yeah.
Nose and throat specimens. That's what we don't have to do.
Yeah, there you go. 7.4, you do not need to know the nose and throat specimen. Okay? But then you'll notice, like, under skills, it has the midstream, and then it says collecting nose and throat. You don't need to know that. Yes. Okay. All right. Number 1, take it away. Okay, so what I'll do then is for group number 1, explain how to obtain for a male, and then group number 4 can explain how to obtain for a female, because they are different. Okay? Go ahead.
Well, I know that you want to educate the patient to void before getting the specimen.
Okay. Okay. So, in Parian powder, on page 169, are the steps for obtaining a midstream clean catch. It's not only important for this class, but it's important to know, okay, because it's pretty specific, I guess is my point, all right? It's pretty specific how you're telling the client to wipe, when you're telling them to go to the bathroom, and it does make a difference because we want the urine that is not right at the beginning of the urethra. We want the urine that's further up, okay? Okay. So, do you think that when you're doing a midstream clean catch that you're actually going to wipe that area first, or are you just peeing?
You wipe first.
Good. Okay, good. So, with a male, they go in circular motions at the tip of the penis. They move from the center to the outside. If they're uncircumcised, they're going to retract the foreskin for effective cleansing, and then keep retracted during voiding, and then return the foreskin when they're done. Okay. How much urine do they need?
You fill up the cup like halfway.
It's 90 to 120 mLs.
Is that just for men?
It's listed underneath of men, but it's the same for women.
I was about to say, why don't we?
120.
Is it 90 to 120 or 90 to
90 to 120, yep. urinate into the toilet or into the bedpan, and then once the stream has been established, then they're going to urinate into the cup, 90 to 120 mLs. And you want to make sure that the specimen container is actually like removed before the stop of the urine, okay? There's also instructions on how to get a clean catch from a Foley, okay? Or not a clean catch, I'm sorry, that's not right. How to get a specimen from a Foley. If you had a Foley, yeah. Yep, but that's all in there, okay? So definitely make sure you guys are reading over your skills. They are testable, okay? So, when we talk about sepsis, we'll talk about some of the skills too, okay? You'll see them again, so just get familiar with them. All right, so interventions for pain management. Let's have group number 9. Yeah. Okay. All right, and we'll talk about that. That's one of your need-to-know drugs. What else can you do?
Adequate fluids.
Okay, Richard said adequate fluids.
Warm sits bath.
Warm sits baths, that's great, yep.
Heat pads.
Okay, what do the heat pads do?
It relaxes the muscles and relieves spasms.
Okay, so he said that heat pads relax the muscles and it helps with spasms. Sometimes that bladder spasms, they can be really painful and really uncomfortable. The book mentions under complementary health some oils that you can add into the sitz baths, and it also talks about like making sure that you're speaking with your providers because cross-sensitization for allergies and stuff like that. So just caution people, with the complementary health. You had a really interesting story. Do you mind sharing it, or?
I have a friend who works at an emergency room in a college town, and in like 1 week they had all of these college girls come in, and they had kidney and bladder infections that were so bad that they couldn't give them IV antibiotics or oral antibiotics. They actually had to go in and inject them like into their bladder and into their kidneys with this with the antibiotics. And if like a normal UTI would like develop in like 2 to 3 days, these girls were having full-blown kidney infections within 48 hours. And they couldn't figure out what was going on until the girls, after interviewing them, they said that they used coconut oil as lubrication for sex.
Oh.
And yes, real life. So coconuts are a fruit and their oil is sugar-based. And the bacteria feeds on sugar. So when you introduce that into the system, that's why it would only take 48 hours for these girls to have like a full-blown kidney infection within 48 hours, and they were like hallucinating, and it was really bad. So they ended up having to contact the university, and they had to send out like a mass email to everybody to tell them, use coconut oil, do not listen to Pinterest, it's fine.
Okay, so again, just an example, okay, and it's a really good example of how fast these things can move, all right? Just how fast things can change in a patient's condition, all right? And a really good example of getting a great health history, right? So asking the right questions, and then in this case, they found that common denominator, right? Like they found something as to why these, I'm assuming, otherwise healthy individuals were getting these massive kidney infections, okay? So importance of, like I said, getting that good health history and knowing that these things can kind of spiral quickly. Okay, so we've said sitz baths, we've said warm compresses, we said the pyridium. What else can we do? Okay, so before we would go to a catheter, we would really want to do some bladder training, because anytime you put any type of instrument, you have the risk of introducing more bacteria. What else? What else? Yeah.
I was actually just talking to my mom about this. Was that like over the counter stuff? She said like ego completely like numbed to the track or something.
Okay, and we'll talk about that with the pyridium, because it's pretty. There's a lot of the over-the-counter medications like that that people will take. Yep. Okay. What else? Anything else? No. Okay. All right. What about fluids?
I know you're in pain.
Would that be something to help decrease the pain?
Increase it.
You did that? I didn't hear you say that. I'm sorry. Okay. Okay, I missed that then. All right, so increased fluids, good. I'm sorry I missed that. Okay. All right, how about community-based care? Let's do, what group was that? We'll do education. Yep, so education group number 13, or we did 13. How about 12?
The causes for UTI, the symptoms to look out for, and if they're on an antibiotic, to finish it.
Okay, good. All right, anything else that we can think of for community-based, or I'm sorry, for education?
I think even just like how to prevent like hygiene and just knowing general things they would, what to do, what not to do.
Mm-hmm. Good. So a lot of those things that we already talked about, right? So making sure that they're increasing their fluids, perineal care for women, wiping front to back. All right. How about effective urinary elimination? What are we going to talk about there? Who wants to go for that? Or should I pick?
Urination because of hydration.
Okay.
Drink that fluid.
Good. Urination and hydration.
You may have to place a catheter if they have retention.
Okay, so if there's retention, that would be, again, there's all of these criteria, right? So like the example, the patient was avoiding because they had a neurogenic bladder, right, for the diabetes. You may have to do something like that. But again, timed voiding, there's a lot of times where they'll, every 2 hours getting patients up to go to the bathroom to see if they have to go to the bathroom. And then they may do bladder scans, something like that, to see if there's incomplete emptying.
Is that like due to void? When they talk about like they're due to void, is that like getting them off the hospital?
So it could be due to void because a catheter was removed at 6 a.m. and then they're due to void in 6 hours by noon, something like that, whatever the hospital's policy is. So if they haven't, then they, would encourage them to go and then we bladder scan them, so whatever their hospital policy is, something like that. Okay. What else can we teach them? So timed, voiding. What about, we talked about some of the caffeinated drinks, the citrus drinks, avoiding alcohol. And then, just as a group, how about health maintenance? Like, what is it really important? Somebody said it. It's very important for these patients to do. Yeah.
Is that the vitamin C thing, or?
So sometimes that's a good point. Some people encourage vitamin C
Because it makes the environment in the bladder like more acidic.
So some people also were encouraged certain drinks to like make it more acidic in the bladder to see if that can help. But that's not something that would be like a nursing intervention. That would be something.
Well, it's a teaching though.
Yep. So, but that would be something I guess that you might have on discharge instructions.
But then you said avoid like oranges. They make it more acidic.
Some citrus juices. So vitamin C isn't just in orange juice. You might take a vitamin C supplement, like a vitamin specific just for vitamin C. Not necessarily getting it like through an orange juice or something that could irritate the bladder. Bladder training, who said that? Yeah, that's great. Yep, bladder training is a good idea.
Especially those guys with pH.
Okay, what about when patients leave the hospital and they still have 4 days left of the antibiotics and they feel great. What's super important? Finish your antibiotics, okay? Make sure that you're finishing the antibiotics. One, you know, patient safety-wise for medication adherence, they need to take that so that they completely eradicate that. But also, when people don't take their antibiotics, it can help increase their risk of super infections. Okie dokie. So, coming down the home stretch, guys, okay? Hang tight.
That's what she said like an hour ago.
All right, so for this next one, we already did this, okay? So, one more down. Now, what I want you guys to do, this is a urinalysis and a culture and sensitivity. Again, it is on your list for your objectives, okay? My expectation is not that you aren't going to be diagnosing anybody with a urinary tract infection, okay? But you will be looking at labs as they come back, okay? So what I want you guys to do is take a look at these, urinalysis, culture, and sensitivity, okay? I want you guys to take a look at them, and just with the partner, it doesn't have to be within your groups, but I want you guys to talk about it and look at the list and tell me which of these antibiotics you think are the ones that are going to be better at getting rid of your urinary tract infection. Okay, so just take a couple minutes, okay? And I don't want you guys to worry about the numbers, okay? Don't worry about those numbers. On here. Don't worry about those.
We're supposed to look at that and see which one.
Complaining of pain when urinating, which is called what? Dysuria. Good. Okay. Beg your pardon? Oh, yes. They might have some strong or foul-smelling urine. Good. They might have increased frequency. They're going a whole lot. What else? Cloudy, right? Says it up there. Okay. Say it again. Okay. Yep. Somebody said odor already. Okay. What about urgency? Okay. Somebody who can explain the difference between frequency and urgency? Sarah.
Okay. Well, frequency is you're actually like putting the fluids in. You're actually emptying your bladder. You're fully urinating. Urgency is you're like, oh, I'm fine, and then you're not.
Okay.
And have to run, and then sometimes.
Okay, that's me.
Okay. Okay. So she said frequency is the actual act of urinating, right? Like you're going to the bathroom all the time, right? You're actually urinating. Urgency is that like sudden, compelling urge to go to the bathroom. Like you feel like I need to go right now. I'm gonna pee my pants. All right, I need to go right now. All right, that's urgency. All right, what else might happen?
I don't know what the actual name is for, but like
Okay.
you feel like you still have to pee even though.
Incomplete emptying. All right, you might have that like feeling that you haven't completely emptied your bladder and you're trying to go and there's nothing there. What about for newborns? What if this was a newborn? Okay. Okay. Good. Irritability. What else?
Increased intake, they're not drinking, they're not eating.
Like a failure to thrive, right? Poor feeding. Katie said fever, right? A lot of times it's an unexplained fever, okay? Got no other explanation for it. Fever of unknown origin. Good. Okay. They may have some vomiting and diarrhea. They may have that strong smelling urine also in newborns. Any child less than 2 years old should be tested for a UTI, for a fever of unknown origin. Okay? How about, we already kind of talked about this as cystitis, suprapubic pain. Where is that? Where is suprapubic pain? Right? You can feel the pubic bone, and it's right above that. Okay, it's not up here at your belly button. All right, it's suprapubic. It's right, pretty far down. Okay. So the book actually has it. It's hard. Look at my bees. I love it.
Did you really?
It's almost like it's a bag collection, but realistically, like it's not really a good.
It's not a, I don't think it's ever technically a
Yeah.
unless you're like passing.
Like I had the symmetry.
Okay.
My dog had been for everyone. My dog she was like a year and a half, and he's like,
There's so many bees.
What about couple other things? What about blood in the urine? Could they have that with the urinary tract infection? Sure, it's irritated, right? That tract is irritated. They could have blood in the urine. Look at this one. They've got 2 to 3. Okay. More sediment, right? Look at the sweat graph, right? Doesn't necessarily mean that they're dehydrated. It's just got a lot more stuff in there. All right. Okay. So, what are we gonna do? Okay. So first, what do the S's mean? What's that mean?
Susceptible or sensitive.
Okay. I hear susceptible. I hear sensitive.
Super good antibiotics.
Okay. So it really means both. The S can mean both, susceptible or sensitive. But what does that really mean? Okay, good. So the sensitivity is there. What it means is the organism is inhibited by the serum concentration of the drug that is achieved using the usual dose. Okay, the usual dose. So like this is the recommended dose for amikacin. And it worked. All right. The numbers to the side, again, you guys don't have to worry about those. They're called minimum inhibitory concentrations, or your MIC for that. All right. In microbiology, you probably talked about this. It's basically the lowest concentration of an antibiotic that inhibits the growth of any given strain of a bacteria. Okay. But again, you guys don't need to worry. I just want you guys to look at this and be able to see that, like, okay, well, ampicillin, the bacteria is resistant to the ampicillin. Okay, do you see here at the top where it says the E. coli greater than 100 organisms per mLs? That is the bacteria count greater than that indicates infection. Okay, so when the culture comes back and it says greater than 100, might say greater than 100 CFU, something like that, then you know that it's indicative of an infection. Now, I didn't put one of these up here, all right, but just FYI, all right, the culture and sensitivity can have eyes on there. What do you think the eyes are?
It's okay.
You might learn if you don't have any.
Louis? Okay, right, so the I means intermediate. Good. All right, the intermediate inhibits only at the maximum recommended dose of that medication. Okay? So this is why somebody that comes in and they're started on, let's just randomly pick one. Let's just say they were started, look, nitrofurantoin is up there. So let's not pick that one. Let's pick one that it's not. Let's say they were started on Cipro, okay? So they're started on Cipro, and they've taken 2 days of Cipro, and they get this back. Right? So this tells us here that Cipro, the bacteria is resistant to the Cipro. I don't know what this in here, I didn't get what the asterisks are, it didn't pull up on this one. But that would, again, so you know that the bacteria is resistant, okay? Again, you guys aren't making changes to medications, you're not diagnosing anything, but you might see this, okay? You might see a culture insensitivity, and you might see your antibiotics change, okay? I just want you guys to have the knowledge that the change could be coming from this, all right? It could be coming because the sensitivity came back, and they found that it was not sensitive to that, okay? Does anybody have any questions on that? All right, now, on your objectives, there are not any diagnostics, right? Just the lab stuff. When I say diagnostics, like there's not a cysto one there, there's nothing like that, right? Okay. Realize though that there are diagnostics. People can have can have cystoscopies done to diagnose things like prostatic hypertrophy, if there's strictures, if there's bladder caliculi, if there's tumors, anything like that. They may also do like a voiding cystoscopy. It basically instills contrast, and then they take an X-ray to assess the bladder and urethra when it fills and when it voids. So there's a lot of different things, especially for people that get reoccurrent urinary tract infections. Okay. Let's look at my last slide, and then we'll go over objectives. So this is one of your medications. It's phenazopyridine. Okay. Who can tell me a little bit about this medicine? So, okay, somebody said it numbs you. What do you guys think about that?
True.
Okay, so it's a non-opioid analgesic, all right? Do you think it gets at the burning?
Yes.
How about if there was any itching?
Yeah.
Okay. So it gets at all of them. Pain, itching, burning, urgency, frequency, yeah. Perfect. So we're going to talk about that. Let's do that. So you have a patient that comes in and they've been taking over-the-counter phenazopyridine, pyridium, and they hand you this clean catch, right? And they don't necessarily tell you about it.
It's bright orange.
So that is one of our nursing things. So when they take this medication, it can interfere with a dipstick, okay? So any of those urine tests that are based on color, that are on, have you guys seen that where you dip it into the urine and you pull it out and it's got like 8 or 10 different things and it's like leukocytes, nitrates, protein, bili, ketones, all of that. So the big ones are glucose, ketones, bili, proteins, and then if they're steroids. So it can mess with that. What else happens? Somebody else said it. What's the big thing that you're going to teach people about this medicine? It will turn your pee bright orange and it will stain stuff. It stains your clothes, okay? So especially if this is somebody that has never taken this medication before, you definitely want to give them a heads up. Hey, he's going to be bright orange because like it is a scary, scary bright orange, okay? So you definitely want to make sure that people know this because if I didn't know that, it would definitely freak me out, okay?
It's still
So it can stain your clothes. So like with women, you might want to tell them to put like a light day pad in their clothing, okay, something like that, because if there's any leakage at all, it can definitely stain your clothes. Does this have any antimicrobial activity? No. Okay. Should people be taking these for days on end? No. Normally after about 2 days, that antibiotic should be kicking in and should be decreasing the pain. Okay, so 2 days of treatment with that antibiotic. They want to take it with or without meals. What do you think? Who says with?
I'll say with.
Okay. Who says without?
more important that you take it with.
Who says it doesn't make a difference?
Doesn't make
No idea.
Okay. So you want to administer it with or following a meal so it decreases GI irritation. Okay? You can't crush it, break it, or chew it. Any other questions about pyridine or phenazopyridine? No? Okay. Real quick, let's get out our objectives. Guys, y'all are troopers. This is the long one, so yourself a round of applause. You had the test, and then you have this, so good job today, guys. I know.
It's really like, go, yes, okay.
Yes.
Yes.
The nose and throat specimen is like in 4 different places. Yes, the nose and throat specimen is gone. Okay. And I just caught it like real quick on that one, and I was like,
I have trust issues.
yes,
Let's
no,
look
you're
at
good.
times.
You are good. Okay, so let's go over the objectives. Does everybody have a copy?
Yes, ma'am.
Okay. We did it on the board.
Okay.
We did it on the board. Yeah, so you're good. If you guys have those brown pieces of paper, it was for you to write down stuff for your concept maps, but we did it up on the board, so you don't need to keep it. You do whatever you want with it.
Pretty good.
As long as I didn't miss something.
No, you did not miss anything. Okay.
Your mental status.
All right, so the objectives. So, we're going to go down one by one, all right? So the first list of objectives, it says demonstrate ways to provide and direct nursing care for client with infection, okay? So I want you guys to think about the things that we did today. What did we list out for cellulitis? Who can tell me a priority for cellulitis? Prevent spread of infection. Good. Okay, how about for pneumonia? What was a priority?
Oxygenation.
Oxygenation, okay. So what nursing interventions do we talk about for pneumonia? What were some of the ones? Head of the bed. We actually did percussion and postural drainage. What are some other nursing interventions?
Cough, deep breathe, and send a spirometer.
Cough, deep breathe, and send a spirometer. Ambulate, good. How about for urinary tract infections? We just did those, right? Increased fluid intake.
Bladder training.
Good.
Time voiding.
Time voiding, bladder training, perineal hygiene, right? Wiping from front to back. Education, good. And that kind of rolls into the next one, apply principles of infection control. All right, so what types of things can you do as a nurse to decrease that spread of infection?
Hand hygiene.
Hand hygiene, right? Wash your hands.